Hello everybody, welcome to the King's Fund and today's online event about ACOs, Accountable Care Organisations. I'm Hugh Alderwick. I'm a Senior Policy Advisor here at the King's Fund. I'm joined by Stephen Rosenthal and Fillmore from the US. I'll let you guys introduce yourselves if that's okay.
Sure. I'm Steve Rosenthal, and I'm the Senior Vice President for Population Health Management for the Montefiore Health System in New York, and I'm President of our care management company.
Fillmore, I work for 3M Health Information Systems as Senior Director for Strategic Innovation in Value-Based Programs. Been doing value-based care strategy and implementation in the U.S. for about 5 years now.
Great. Thank you both for being here. We're very appreciative and hopefully the audience will get a lot out of it. So as I say, today's session is about ACOs, but specifically the work going on in New York. And it's a chance to understand how the ACO operates and works in practice and some of the lessons for the work going on in the NHS. But just in case you're someone who's logged in and thinking, what on earth is an ACO? So we'll hear from you guys about what it means in New York, but very broadly speaking, an accountable care organisation is a group of providers who agree to work together to manage and deliver care for a defined population. They do that typically with a contract from an insurer in America, a commissioner here, which defines the quality and outcomes that are to be delivered within a fixed budget. So lots of talk about ACOs here after the 5-year forward view and part of the STP plans. So we're going to hear much more about what it means in the US context. Before we get on to questions, I thought it'd be briefly worth setting out how the session's going to run. So we've got about 55 minutes, an hour, largely for questions from the people watching, the audience, you. I'll ask 4 or 5 questions to Steve and Herb just to get things going and set the context. But then on your screen, it should be obvious as a place where you can ask questions. Please start submitting them now and throughout the session. I've got a screen where I'll be able to see the questions and I'll feed them to you too. So we'll start with some questions from me and then we'll go to questions from the audience. Hope that's clear. Did that make sense? Very good.
Sounds good.
So I've given a brief outline of what ACOs are, at least I think they are from the English context, but all ACOs are a bit different. Tell us about your ACO, the sorts of services it provides to give us an idea of what it means in your context.
Sure, thank you. Well, I think your definition was a good general definition. ACOs came to be known largely as a result of legislation that came about under the Obama administration called the Accountable Care Act. Prior to that, what used to be an ACO was called many other things, IPAs, integrated networks, and essentially they're all what Hugh described. They're organizational structures where a fiduciary body brings together a group of physicians. Those physicians begin to manage a contract relative to a population, and that population gets serviced by that network based on the terms of that value-based or related contract. What we've been doing over the years is largely trying to build a base of population that we're managing financially at risk. We built a network that covers a fairly sizable geography in the northern parts of New York, in communities called the Bronx and the Hudson Valley. And in there we have almost 5,000 physicians, individual physician groups, and these groups join our network. And based on their attribution with the various health plans that we have contracts with, we then become financially responsible for that population. Today we're managing about 400,000 lives in these various contracts, totaling about $2.6 billion in at-risk funds. And what we do is we look at that population that we're servicing, these roughly 400,000 individuals. We stratify them, and we've built an infrastructure that helps support the network and manage that population over time.
And so give us a feel for the sorts of services you've got. So is it hospitals, primary care, home care? Is it the full range of health services involved in your ACO?
Yes. It's literally the full continuum of care. We do everything from basic primary care to heart transplants, kidney, lung transplants. So it's a full academic integrated delivery system with all of the requisite bells and whistles. We have our own home health agency that delivers over 500,000 visits a year. We have our own IT technology company that manages the technology across all of those various businesses. We have a large owned primary care network, about 700 primary care physicians in 23 locations throughout the geography that I mentioned to you. We have about 1,100 specialists that are employed in our faculty practices that cover that in every specialty known to man, probably a few that aren't. And all of those providers are participating in our network. And so the goal is, obviously, is to create market share, keep as much of the population that we're servicing within our network, and manage the care in a way that we improve both the quality and lower the cost over time.
That's really helpful. And so, as you say, the main objective is to improve the lives of the people that you're serving. So for that sort of person who's living in the Bronx and is covered under your ACO, what does it mean? You know, so you talk about population health management. What does that mean in practice, both for the people who are getting the care, but also for the way doctors, nurses, social care workers, they work together to deliver that care? So what does it mean in practice?
Well, in large part, much of it is transparent to the patient. That only becomes apparent to the patient if the patient becomes one of those individuals we think we need to intervene and or help. And so as we stratify the population that we look at, you know, using the Pareto rule that 20% of the population is driving 80% of the cost, we look to that 20% of the population, who's seeing them, how they're being cared, and we develop programs to assess and evaluate them. And over the years, we've created a fairly organized, systematic approach to doing that so that we can scale appropriately and have a return on investment that makes sense. You don't want to spend all the money you save on infrastructure to support the population. You want to create a balance so there's an opportunity to use the dollars that you save by better managing the care to help sustain and grow the clinical programs as well as the infrastructure to support them.
So it sounds like you're using data about the sorts of conditions people have, how often they use services, to segment them into different groups. Is that right? And so you've got the high needs group where you're putting in place a range of services, but I suppose it also matters to improve quality for the rest of them. So they just have different services tailored to their different needs. Is that how it works?
Yeah, no, absolutely. And I think there's a whole range of quality measures that become part of the standard portfolio. There's many of them, unfortunately. With some of the government ACO projects, there are as many as 38 measures that are part of that quality score. So the way the value-based arrangements work is that if you actually were able to save, let's say, $1 million, but your quality score was only a 70%, you would only get 70% of the $1 million. And if your quality score below a certain percentile completely, you would get nothing.
So you've got linked cost quality incentives.
Right. And the concept there was that, historically, many, many years ago, managed care was viewed to be price only.
Yeah.
And so they wanted to not really replicate a bad history, but use quality as the motivator. Clearly, if we get better quality care, if you're providing quality care, there's an assumption you're lowering costs because you're doing the best job you can.
So what happens within your network? Because as you say, there's an assumption sometimes you can take cost out of the system, but often that might mean avoiding unnecessary hospitalizations, for instance. Mm-hmm. We know there's a lot of money tied up in the acute system, both in the US and in the UK. What happens for a hospital? What's in it for them? If they're seeing some admissions reduced, they might lose income under traditional fee-for-service. How do you manage the risk within the network?
Well, it's a good question. The first thing to remember is that the patient is the most important part first. So doing what's right is always the most important next step. To the extent that it avoids an unnecessary admission because we're able to provide better services on an ambulatory basis, the hospital, one, participates in the overall goals and assumptions of the overall network, so it will benefit to some degree, not dollar for dollar, but to some degree. But the hospital also has the ability to lower its expenses. So if its volume is dropping, it could lower the expenses. Also, hospitals in the United States, at least, their payment is often based not only on the unit cost, but on the severity of illness. So if hospitals are taking care of patients who are more ill and their case mix index is higher, they'll be making up for that lost payment by seeing more sicker patients who they'll be getting paid more money for anyway. So there's a delicate balance, and it's an educational process that hospitals have to go through, since so much of their cost is fixed costs, because the building is there, and people are what drives 95% of the costs in hospitals. So it's a slow change process, and that's why the hospitals have to be part of the model, not outside the model looking in.
And so it sounds like, so to play it back to you to make sure I've understood right, there's a few different things at play. The first is there's some level of risk share arrangement where if actually we're saving money because we're doing better for patients, we'll share some of the savings with the hospital.
Correct.
The second is they can reduce some of their costs because they don't need some of that variable cost, maybe staff.
Exactly.
And the third is they can actually treat the more severe, sickest patients, which is what they're there to do anyway, so they're focusing on the most important work.
You got it.
Right. So a question for both of you here, talking about stratifying the population, segmentation, how do you do it? It sounds like it's sort of quite complicated using data, IT. Is that how it works?
Well, it could be complicated, and I think, what's your name again? Herb. Herb will share. Herb will tell you. But from we use Post-its, so it's not complicated for us. Yellow Post-its, no.
Go on, Herb, tell us.
I'll let Herb tell
3M product.
It's also a 3M product.
Go on, Herb, talks about population segmentation.
I think I like to segment population segmentation into 4 buckets.
Crikey.
First, there's your physical and your behavioral health status. And so when we think about trying to manage populations, we want to understand what's their health status, their physical health status, and their behavioral health status. There are a number of systems out there for doing that, which are good. My recommendation would be, and our experience is really solid on this, that you get a system that's categorical, that has a clinical basis to it, so the clinicians understand if you're talking about this is a group of multi-morbid individuals who have diabetes and a series of other significant problems, that they can use that information to plan programs and evaluate what they're doing for a population. The second area, and the same thing with behavioral health. So you look at a good system. We have the CRGs. Johns Hopkins has the ACGs. There are different systems out there. But that's where you start. From there, you need to look at functional status. Functional status is key these days as we bring in these other populations with long-term needs. We need to look at functional status. We have found that the interrelationship between physical, behavioral, and functional status needs is very significant, and it helps you, again, identify that population where you can have the highest impact, both on your quality scores and on your cost, okay? Quality is for everybody. We have to deliver that for every patient, but individuals with critical needs will impact your quality scores much more. And in a value-based ACO environment, being able to perform on quality is the key to success, and it's key to good care. So functional status, and here I'm talking about self-care mobility, incontinence, and cognitive deficits. Those are key, and they interact differently with the different physical and behavioral health. Third pillar is readiness for change, patient activation. Those are key things that we need to understand. It's hard to systematically collect, but we need to collect it because a patient needs to be engaged in this process. And those segments of the population which can be engaged, which we're successful in engaging with, we're going to go very, very far.
So let me start. So you're actively collecting data on how activated patients are?
We actually are. In some states, we have a very broad application, which is actually incentivized. So patients actually are incentivized to fill out. It's a special kind of health risk assessment that gets at that. And then the fourth pillar is, of course, the social determinants, and those are the areas, and I'll throw in cultural determinants as well. but it's those things that we're all talking about these days. And again, we either need to collect that directly or impute it based on where, place-based, where do people live. If you put all those things together, you begin to segment a population in terms of what their characteristics are, and then you layer in their utilization patterns, because utilization patterns tell you a little bit about their preference for services and whether or not the system is meeting their needs. Because if the system is responding chaotically to one of these individuals who has cognitive deficits, behavioral issues, high multimorbidity, and a lot of social determinants issues, and they're not activated, and the system is responding to that chaotically, he's got a real problem.
Right.
So that's where he puts a lot of his time.
Right.
That's super helpful. And so it leads me to a question that I wanted to ask anyway, is that ACOs here in the United States are often criticized for being overly medically focused, all about doctors, nurses, hospital care, medical treatment. But as you've talked about, social issues like housing, poverty, food security, transportation quite often in the US are the big issues which are driving their health outcomes. So you can't do all of that within your ACO, but what do you do to A, directly address those needs, but also link with others, other agencies, other providers who do address those social needs?
No, that's a great point. And I think that, and I said this earlier too, is that what's really evolving in this whole arena of care management under an ACO environment is that we're becoming more engaged in managing the patient's life. And so when you talk about the fact that there are these clinical opportunities or issues with the patients, I find by and large over the many years that I've been doing this is that physicians generally do a pretty good job. Maybe they'll miss a gap here or there and they'll take the information, but in general, they're generally managing the patient well. Where the challenges come in on the patient's ability to maintain compliance and deal with the ramifications of the social impact on their need to be observant and compliant with their health status. So we have built into our care management structure essentially all of the abilities to kind of manage these
Socioeconomic?
Socioeconomic, thank you. I couldn't get the word out. Listen to what's the accents here,
You were trying to do an English accent.
Yes, I was trying. I apologize. So these socioeconomic challenges have to be dealt with in the context of managing the patient. So you have to recognize that transportation could be a real limitation around compliance. Mom's got 3 kids. She's taking one for an appointment. Well, she's got to take the whole family for that appointment. And how do they all get there? Somebody who doesn't have the sufficient funds for the co-payments or the refill of a prescription becomes non-compliant, or takes half their prescription because they want it to last twice as long.
Right.
So all of these social challenges that you have to intervene on become part of the assessment process. So when we're looking at a patient who is in that category of I want to know more about them, we go through a fairly extensive assessment, as Herb described. Based on that assessment, we put together a problem list. And then based on the problem list, we generate the interventions based on that. And then we continuously monitor those interventions to see how that patient is actually doing on them, and are we actually getting the benefits that we were hoping to achieve. So we have to actually build the skill sets within our care management organization to deal with transportation, to deal with housing, and to deal with the financial distresses that many of us, regardless of our socioeconomic standing, are dealing with.
And so I'm going to go to questions from the audience in a minute, but does that mean that those sorts of services which are non-medical, more socially focused, are they reflected on your governance as an organisation? How do you sort of work with those groups at sort of a higher level so you can make decisions and you can be more strategic with those sorts of organisations? Does that happen?
Oh, yeah, no, absolutely. I mean, these are organised companies. We call them community-based organizations.
Right.
They are active. Some of them are grant-funded organizations. Some of them are actually funded by the City of New York. There is a housing program, for example, that we have a contract with that is paid for by the City of New York to keep the homeless individuals off the streets and help them move into some form of subsidized housing so that they would have a better outcome as well.
And so we had a question that came in even before the session had started, which I've already seen, which is about GPs. Do you call them GPs in your system? Primary care physicians. So,
yeah, primary care physicians.
Yeah. So in primary care, we've got really big pressure on GP practices, long waiting lists sometimes to get an appointment. Mm-hmm. Can't get one on the day if you want one on the day. Difficulty with burnout, stress, really big workload for GPs who are seeing lots of patients. What sorts of things have you put in place to improve the lives of those GPs and the care they can give? How have you changed how that primary care practice works?
Yeah, well, I can tell you that we're facing very similar problems in the United States. There is a tremendous amount of burden on the primary care physician because of the nature of the expectations of what he or she will be doing. What we've recognized is that you have to be able to support them. And in large part, the building of our network around our ACO has created an infrastructure that supports the primary care physician practice. We offer the primary care physician the use of extenders, nurse practitioners, and other resources. As they build out, we call them patient-centered medical homes.
Right.
I think you use community-based status for that here. Very similar. We offer them tools to manage the mental health and substance abuse patients within their primary care practice. So we're giving them lots of tools and lots of support, recognizing that they can't really do it all themselves. And that, I think, has begun to make their jobs a little bit more functional, a little bit more useful, and they're much more willing to be cooperative and work with us because we're helping them deal with the patients. We don't send them information that can't be acted upon. They don't need just information, they need action items. So over the years, we've kind of learned what's important, and then we've been systematically giving them more and more assistance so that they can make their practice more tolerable.
Can I add something to that?
Oh, please do, Herb, yeah.
What's really important here is that this type of thinking is the outgrowth of systems-based approach to healthcare. And the idea that a wraparound service, a systems approach to supporting physicians and their patients is going to really achieve the kind of structural and long-term change that we want. And there's a key implication here. As you all move forward with the changes that you're going to take place, of course you cannot balance transformation on the back of a GP. So you have to put systems in place, and two of those systems, which are metrics and the information that drives those metrics, and of course the financing, has to take into account that there's a system in play here and it's not all about the GP. So don't have only metrics for value that are solely about the GP. So metrics must span beyond that.
So this is another question we had earlier before we even came on about metrics. It's just learning for improvement. So you've got quality metrics for your contract. You can share savings if you meet some quality measures. But to improve performance, we know you need data on how you're doing. You need to know how you differ to the guy next door or the woman next door and how they're delivering clinical services. How do you use data to support improvement within the ACO for clinicians?
Well, in just the way that you described, we use a 3M product, just coincidentally, that allows us to look at their historical claim data, and because we also have a large electronic medical record that's the same throughout our system, we're also able to incorporate that and give the physician information about how they're performing for their population and how that compares to their peers. And we try to even do that by cohort, looking at how they're managing their diabetics relative to their peers, their heart failure patients relative to their peers, and so they at least get an understanding of what the challenges are and gaps. But one of the things that we've discovered over the years, and I'm not really sure if it's a good thing or a bad thing anymore, but physicians, even though we're providing a lot of assistance to help them, the ability for a practicing physician or a group of physicians to sit down and spend the time to understand what's happening to the cohort of patients that they care for when their day is one patient at a time is not always a practical outcome. Mm-hmm. For as well-meaning as they'd like to be, they can't really spend the time analyzing it. So what we do is we provide them a resource to give them summary updates and clarification information so that they have some knowledge about what's going on, recognizing that they may or may not do it themselves.
Right.
So again, helping them understand the data by giving them a resource to help translate that information for them on somewhat of a real-time basis.
So if I'm a GP, say, I might get a monthly dashboard, or is it weekly dashboard? This is
monthly,
how I'm doing
usually.
Monthly dashboard, and that'll show variation against others. So you're using data to change service. So we've got the technology glitch. Now we've got a laptop rather than a screen. Lots of questions have come in. I mentioned to you before we started, we've got these things called STPs, Sustainability and Transformation Plans is the jargon, where different parts of the country are making a plan for improving services. I think probably linked to that, we've got a question about how did you start? Did you have a big plan? Was it a strategy, or was this more evolutionary? Did you start with a big vision? How did you get started? How long have you been going?
Well, April 15th, we celebrated 21 years. And 21 years ago, we were looking at what was going on around the country, and the leadership at Montefiore at that time, the previous CEO, really believed that capitation, or being prepaid, was a more rational approach for healthcare dollars than a fee-for-service environment. So we set about beginning that process then, thinking that it was a more rational and more incentive-oriented way of managing the business than just transaction reimbursements, because then to make more money, you just need more transactions, and is that always better for the patient? So this was really about how do you transform a system that's better for the patient. Also, as I mentioned earlier in another discussion, 85% of the business in the Bronx that we manage is government programs. So for all intents and purposes, we are a single-payer system.
Right.
Very different, not any different than you all in that way. And so from our perspective, that was really the only way that we would survive, is that if we didn't have that prepayment and we weren't able to manage the dollars within that prepaid environment around the government programs, the transaction revenue wouldn't be enough to sustain us.
Right.
We would be in much more financial distress. But because we were able to use the benefits of those dollars, it was able to sustain ourselves in a much better and have much improved financial outcomes over the course of those years. And so it was a systematic process that we believed was the right way from the beginning. It was long before people thought about the Accountable Care Act and long before Obama.
Yeah.
I mean, when Obama came into play, all of a sudden we were an important piece of business because we were doing it. But it wasn't as though we created it for that purpose.
So this stuff takes time. It's not a quick fix. It needs constancy of purpose. We've got a couple of questions coming in about things to do with getting started, but I think also, as you'll still be doing the stuff about engaging with different stakeholders. So oftentimes you'll have places in the NHS where they feel like they have to engage with absolutely everybody under the sun before they can get going, and probably that's the right thing. Have you had problems with engaging enough people, being able to speak to the voluntary organisations, community-based organisations? How do you keep up all those different conversations and keep everybody involved who needs to be involved?
Well, I think that's another thing that occurs over time. It really is something that takes place over time. I think there's a common message that this is a better way of doing things. It focuses our resources on the patient and on quality. And those are two options that are hard to refute. And it also provides an unusual opportunity to provide incentives to providers for doing the right thing. And so that's a hard thing to also not think makes a good deal of sense. But it is a gradual process, and it takes time for people to feel comfortable with that. And as long as you're transparent, and as long as you're always being forthright and truthful with the providers, they come on board over time. But you're absolutely right, it takes time. 21 years, it's taken a long time for people to be comfortable with that process. And now as we're expanding our network into the Hudson Valley, it's like you're starting all over again. You have to make them feel comfortable again as well. And it just takes time and being consistent and repetitive and transparent.
And so because you've got hospitals in your system, we've got a few questions coming in about the role of hospitals in ACOs. I've got a great question from Jeffrey Rivet, who's an NHS historian, written lots of books about the history of the NHS and particularly London system. We've got lots of hospitals in London. So what happens in your network if somebody wants to go to a hospital that might not be covered in your ACO? Or if I'm a patient, can I only go to the hospitals that are part of your network? How does that work with the boundary issues?
Well, the way under the government program for ACOs for the Medicare population, there are no limits to the networks that those patients can go to.
Right.
There are almost no hospitals in the United States that don't accept Medicare.
Right.
However, on the physician side of the equation, there are providers who do not accept Medicare, and in those instances, obviously, if they went there, either they were in the program or not, they'd be paying for that service out of their own pocket. But you see that in a very limited way, if at all, in the New York market. And then when you're contracting with health plans, the member is entitled to go to hospitals that are participating with that health plan, which become part of your ACO. So the biggest challenge that ACOs have is patients going to hospitals that are part of a health plan but not in the ACO network. And that out-of-network leakage, as we call it, is one of the areas that we work to avoid as much as we can. Right. So that is a challenge, because whenever money goes out of your network, it's a check you have to write to somebody else.
Plus, I suppose you can't control the quality in the same way as you can within your network.
Can't control the quality in the same way, and even if the price were cheaper, you lose the opportunity at the continuity of care, right, which may have much more value to you.
So we've talked a lot about different providers, IT, some technical things. Quite a few questions come in about engaging with patients and the people under the ACO contracts. So for both of you, what are the strategies that are used? You talked about activation, you've both talked about engagement. How do you explain to people that, actually sometimes they have to take on more responsibility for managing their health with your support and the right support, taking into account their context? How have you had those sorts of conversations? What are the practical things you actually do to change the way patients behave so they can be more healthy?
Well, there's two fundamental mechanisms that we've been using over the last number of years. One is in the process of segmenting the population and identifying that segment of the population that you want to intervene with to provide some additional services, perhaps to avoid unnecessary medical expense or improve quality, as you go through a process of enrollment. And in that enrollment process, it's really a conversation with the patient about why you want to intervene and what that means in terms of their overall health status and what we're trying to accomplish with them. And by giving them that level of information, as opposed to just providing them a service without their understanding and knowledge, we find that 97% of the people are encouraged to participate. So with that encouraged to participate piece, we see that we get a much better response from the patient in terms of compliance and focus on the goals and objectives that we establish for them in that planning process as we develop a care plan for them. So that becomes a very important component of it. And the other side of the equation is that under the government program now, we're actually encouraged and allowed to give the patient an incentive, a financial incentive, if we think it makes sense, to have them do things that would be consistent with good quality care. So in some instances, we could waive a co-payment for certain services if they're consistent with what we would like that patient to do better in, right, like going to see their psychologist or psychiatrist on a regular basis, or have certain kinds of planned physician visits that perhaps they're not compliant with. Their annual wellness visit, they can get a $20 bonus. If members in good standing who are compliant with their program get a small dollar amount to pay for non-pharmaceutical off-the-shelf services in drugstores. And so these incentives are to keep the patient within your network and to keep the patient focused on that there's a community that's there to help them when they need help around their care.
Go ahead.
Well, I would add something. Stephen went past it, and I just want to draw back for a minute and highlight it. He has hired some very special people to engage with the members that he's identified that need care. And he's really trained up those folks who may be from the community, maybe social workers, maybe nurses, to really have the conversation in a way that the patient understands or the person understands, why are we having this conversation? I want to make a distinction here between event-based care management. Event-based care management happens after a hospitalization, during an ER visit, something like that. And when that happens, most people want help. They're looking. If you come up to them and you offer them help, they're going to respond. But there's another kind of care management that's more preventive, and it's looking for the individual who has a long-term need, which is a chronic need for attention and care. And we might find those individuals through segmentation or predictive analytics. When we find those people and we try and enter their lives with care management, and we pick up the phone, they want to know why you're calling them. It requires a very high degree of skill to begin to talk to them about the idea that I'm a coach, I'm here to help you, we actually care. We are doing this kind of work with a number of people. We've worked with Montefiore for a long time, and one of the things that I've noticed with individuals who have a long-term chronic need for care management, because their interaction with the healthcare system is somewhat chaotic, and they have a whole series of those items that I was talking about before. One of the things that we've found, and I've heard this refrain over and over, is that those patients, when you're talking to them, will say, I've learned to live with it. That's not our quality measure. You've learned to live with it. So hiring the right people that can have these conversations to help them understand you don't have to live with it anymore. And if you're ready to work with me, I'm ready to work with you. And we've got the tools to do it. It's really key. And his success rate on this is really phenomenal.
So it's a certain type of person with empathy who's more of a coach rather than someone who's medical staff. And it sounds like it's not just saying what's the right medical support, but the things you were talking about earlier, housing, transportation, how can we improve your life? Is that a fair summary?
Yeah, no, that's fair. We actually, one of our physician leaders uses the term real life. Let's focus in on real life. A quick, interesting example is that we have this gentleman who had 37 visits to the emergency room in 6 months. And during that 37 visits, he was actually hospitalized 9 times in that period of time. And so we went about trying to understand him. Quick story, he's a cab driver. Cab drivers in New York City, and I'm sure here as well, they work 12-hour shifts, sometimes 6 days, sometimes 7 days a week. They don't necessarily have the best eating habits. He is a diabetic, so what does he do? He stops off periodically when he has a few minutes and grabs something to eat that's not terribly healthy at the bodega, and then goes back into his cab to drive. So he keeps on getting sick and going to the emergency room. So the care manager just intervenes and sits down with him and works out a schedule for when he can stop, eat, and deal with his life circumstances, teaches him what he could eat, and then at the same time was able to actually keep him focused on the key items that he needed to do to manage his diabetes. Well, after those interventions, he never showed up in the emergency room again. He kept his semi-annual visits to his doctor. His diabetic educator met him at a bodega once every month for 20 minutes or so. He would often buy her a soda. He was a very nice guy. And so I often use the example of how Juan overcame his exacerbation of his diabetes, and really he's never been to the emergency room again. Simple things.
And so it sounds like, again, reflecting on the various answers you've given, when people talk about population health management or population health, you're looking at the whole population, but also it's one person at a time. So it's what are the needs across everybody we're looking after, and also at a very individual personal level, one person, one family.
The whole person.
And so we've got a few questions here. We often, people here think we can't ever talk about structure, and that's quite right. We often get lost talking about organisations, mergers, when it's care, delivery that really matters. However, lots of questions about structure. People are asking, can you clarify, are you a single merged organisation? Do you have the balance sheet for all of the services you're talking about? Or is this more of a network where you've got to coordinate between different parts of your system? The latter would be more like the NHS, where actually we've got a hospital who's not the same organisation as the community services provider, in some instances, not the same as the GP. So it's more of a network. So how does your system fit? Are you a single organisation or what?
So we're a single organization. It's obviously a little bit more complicated from a corporate structure perspective, but it's a single organization. And it does not incorporate in that single organization those physicians who work in the communities independent of us.
Right.
But we own 12 facilities, and we own 3,000 physicians and many ambulatory sites and buildings, and that's all part of one financial model.
So you've got some you work with who are more on a network basis, who are independent physicians working in the community.
Right, but they're not on our balance sheet. We don't own them.
So you don't. So there's a big merged organisation and some coordination with others who aren't part. So there's a bit of both.
Right.
That's very helpful. So you've got a couple of other questions about size. People often get locked into discussions in their health system about how many people do we need to be looking after for it to be the right size ACO. And there's probably more evidence about the minimum size rather than what's the right size at the other end. But from your perspective, how many patients? You say nearly 1 million, but what was the right size? We had enough critical mass to invest in some of these programs you're talking about.
Well, I think you have to modulate it relative to the size of the organization that you're in, whatever your ACO is or your delivery system is. Scale is important when you're managing risk, when you're managing lives. So big is not a bad thing necessarily because it allows you to spread cost over a much larger group of individuals. Small is always risky because if you have some very high problematic cases, it could give you a financial skewing in the wrong direction. So it's a little bit of a relative term based on the size of your network, but it would seem to me that if you're managing 25,000 or more lives, there's potentially enough spread to give you some flexibility.
Right.
But the more the merrier.
Yeah, so it's more minimum and then perhaps scale matters less the higher you go, but around 20,000 seems like.
25,000. I think one of the mistakes that the Accountable Care Act made in the Medicare demonstration project called the MSSP was that they required the minimum to be 5,000 lives. Right. And I really don't think that that's really enough to get people engaged, because if you've got 150 physicians in that network, how many patients are going to be in each doctor's panel? Yeah. Be very small, very hard to get them engaged if they don't have enough patients in
That's
their
helpful
panel.
Because here we've often got GP groups starting to work together for populations, say 30,000, 50,000, sometimes 100,000.
Yeah.
You've got these bigger STP areas, sometimes as much as 1 million, 2 million people. So we've got these different sizes, but often not as low as 5,000 for sure, not as low as 20,000 often. So we've got a couple of questions about quality metrics and performance. So we've talked at various times about metrics on variation, for instance, to improve performance, the sort of quality measures which allow you to share savings if you meet them from the payer's perspective. So in terms of your ACO and how you measure quality, who decides what the metrics are? Who decides what sort of quality scores are important? Is it all come from the payer, or do you say, actually, what's important to us as an organisation? How does it work?
Well, actually, almost all of them come from the payers or the national quality standards, and there's a fair amount of overlap, and so there's not a lot of genius in that. It's really they're covering the ocean with all of their measures. The real issue is, do you need that many measures, and what are the key measures within those categories that are important to you that you should be more focused on than the large numbers? For example, in the next generation ACO, which is the newest version of the accountable care model under the original plan, there are 38 measures, and within some of those measures there are multiple additional measures. So is that the right number? Some of our health plan partners have 24 measures that they ask us, but the key areas is they're looking at heart failure patients, they're looking at diabetic patients, they're looking at respiratory patients, and then they're looking at efficiency measures. Do you have a lot of readmissions? Are your patients showing up in the emergency room to a greater extent than other populations? And so it's the combination of all of those that are driving much of that. But I don't know whether, Herb, you have an opinion on it, but finding that quotient of the right number is really what the challenge, I think, is right now.
Particularly, I guess, if you've got multiple contracts, you could have measures coming out of your ears. So,
exactly.
Herb, what have you seen about your work in different parts of the US about defining what's important from our ACO's perspective?
He knows I have an opinion on this.
That's why I passed it to him.
I think the fewer measures, the better.
Right.
The more that they focus on the system, the better. I think the evidence is pretty strong that, when you focus on individual diseases and individual disease processes, that you don't really create structural change that will last. And we got a big study in the UK, 2012, where they looked at the process of paying for individual measures, and you'd focus 1 year on this measure, it would get better, everything else would kind of plateau. Next year you go to a different measure, this one drops and that one goes up. You need something that looks at the system. A couple were mentioned here, whether it's readmission, potentially preventable ambulatory care sensitive condition admissions, or ambulatory care sensitive condition ER visits, or you can look at preference sensitive services, which is the old STEEP paradigm for quality. One of those E's is for efficiency. So efficiency is part of quality, and I think that trying to rein in unnecessary and duplicative services is really important. And in order to do that, it requires a system. It requires coordination across the continuum in order to know that the right services are being delivered. I'm a big fan of continuity of care. You can measure that systematically. So there are some, and again, that requires a system approach. So I think that the disease-focused process measures have their place, especially for evaluating at the local level, interventions for particular populations and diseases. But I think for an ACO, a value-based program, you really need a few measures that everybody can focus on, everybody can rally around, you can measure them continuously for continuous quality improvement, and get those fixed and then move on.
So I've got a follow-up question then. So ACO contracts, as I understand it, is all of the medical care for a person. So you're talking about whole person care earlier. It's language that actually we had a few years ago to describe some plans. But sometimes you've got different parts of the country here are looking to develop contracts based on diseases. So, for instance, a capitated budget for the diabetic population. And so I guess your perspective would be, look, think about the whole population, all of their needs, rather than creating new disease-based silos. Is that right?
Well, that would be my position, and I would just say, if you're deciding to go for a diabetic population, even within that population, risk adjustment is very important. Not all diabetics are the same. They have different severity levels. They have different levels of comorbid conditions. So whatever you do, I would think you would want to look at the whole population, but sometimes you want to bite off a piece. But, this gets back to scale. Yep. If you're going to wheel around your entire system and make all of these arrangements and create all these coalitions and create these IT systems and these reporting systems, why would you do that for one population? The spillover is going to be large. Why not gather it all in and do what's right for everyone and get it done? But again, I will strongly suggest that the payment rates and the quality measures all need to be risk adjusted with robust, clinically valid measurement systems. Because if you don't, what's the first thing you're going to hear from the practitioners? Those aren't my patients. That's not, my patients are sicker than that. That's you don't want that. You want to do it right. You want to pay right. You want to measure right.
Really helpful, Herb. Really helpful. A question coming in from a couple of people about leadership of the ACO and physician leadership. So people often say here that engaging clinicians is really important. We've got to have clinically led ACOs or whatever other jargon you're using to describe your system. So how have you encouraged physician leadership, clinical leadership in your ACO, and what role do clinicians take in the management of the organisation?
Well, leadership is essentially the key. And I said to you, we're doing this for 22 years because leadership came and said this was the right way to do it. He had a vision, and he wanted to move that vision. I think many of us adopted that vision over time, but clearly leadership is critical. It has to be a top-down exercise. And part of the challenge in lots of organizations and lots of countries is that the leadership often is fragmented. There are perhaps many leaders with slightly different versions, and that creates a certain amount of chaos. And so to the extent that one can keep leadership focused, it's a critical element. Physicians need to play an important role in that process, but they don't need to play the important role in areas that are outside their skill set. They need to play the role in improving the care of the populations that we serve by thinking innovatively. They need to focus in on the quality and efficiency opportunities, issues around access, and begin to use technology in a way that perhaps enables their practice and their peers' practice to be more efficient and ultimately more accessible to the population.
And so another set of people that we're getting questions about is commissioners, so payers in your system. There's often a discussion in local areas here about what's the role of commissioners and providers in setting up an ACO. So do your payers sit on your board, for instance? Are they involved in governance, or is there quite a big separation between the payer and the provider in your system?
Well, unfortunately, the payers really don't get involved at that level in anybody's system in the U.S. that I'm aware of, unless they bought you. And that does happen in the United States. But the payer piece is a critical element of your success, because you can go out and build a network, get a wonderful set of providers. Those providers have patients, but those patients are covered by an insurance company. And so now you need to go to the insurance company. But because you have a large network of providers that touch a large number of individuals, you now have a large motivation, as does the insurance company, to work together. So if you're small and you're only dealing with a small population, you're not easily going to leverage the insurance company. But if you're as big as an organization as we potentially are, you can sit down with an insurance company and say, look, we touch 100,000 of your lives. These are the things we'd like to do together.
Right.
And we've come to the point where it's important for a lot of the insurance companies to recognize that as a large ACO network, we can't deal with contracts on a silo basis. If they're in 3 different lines of business, we have to be in 3 different lines of business with them. We have to have similar contractual relationships in those lines of business. Otherwise, it's too difficult to manage the relationship, and it costs us money to manage a relationship that isn't giving us the financial opportunities. So that relationship with the insurance company is changing.
Right.
And as networks get larger, I think there'll be more and more pressure on the insurance companies to play a different role. What that role will be, yet to be defined.
So we're getting to the last few minutes, and so there's a few questions coming in, and now's the right time to ask about impact. Is that making any difference? So a question for both of you here. So first about your ACO. So you've been very modest and haven't said you're one of the top performing ACOs in America. Tell us a bit about the impact you're having on people's lives, but also, are you saving any money?
Well, I like to think we're having a lot of impact on people's lives, because certainly we're making certain things a lot easier for them just by virtue of us being in a position to help. Because remember, if there's nobody there to help you, there's nobody there to help you. Yes, we are making money. We did very well in the government initiative. We saved the federal government about $70 million. And our share of that was roughly half.
And did you then reinvest that in new services?
No, that was all for me.
It's
No,
the US,
of course.
it's the US, right?
Yes, of course. We reinvested all of it back into the network. One, to grow more infrastructure to service more patients, because as I said earlier, it takes money to touch a large number of patients. You have more money, you can touch more patients. And the thinking is, if I touch more patients, I can have more savings.
Yeah, and so it's a virtuous cycle. You do better quality care, you can share some savings, and you can then reinvest those savings in new programs.
Correct.
So if you have skin in the game, as you say, you can improve care by doing things better.
Correct.
And so we've had a few questions where people have said, really impressed with both of you talking about social determinants of health, non-medical needs. When you're measuring impact, it's very difficult to know the impact you're having on those social needs. Is that something that you see people measuring, Herb, in the States? Or are they largely just acting on those non-medical needs to see an impact in the more medical quality metrics they have?
Right. There's 2 reasons that social determinants is such a hot topic. One is care management, trying to take care of someone and their environment and approach it systemically. From a public health perspective on trying to deal with that situation. And the other reason is risk adjustment. There's a great concern that some of the methods for both quality and payment don't take into account the fact that certain providers are working in environments with populations which present much greater challenges than other populations. So both of those factors, and I'm not going to weigh in on that question at this point. I think it's It's an outstanding question, and it's got a lot of nuances. So the issue of how and when social determinants should be used for risk adjustment, we'll say it's an open question. But there's no question that they're needed for care management. In terms of your question, are we evaluating, once we had that data and people started using it, were we actually able to, on a broad scale or even on a small scale, affect local situations? And so there are examples of beginning to, I don't know what the right phrase would be, but water a food desert, bring food in, encourage food into an area, of changing a care desert where there are no services, no primary care services, to have that come into an area, of putting in place literacy and cultural counseling. That's not going to change the basic situation, but it's going to deal with it. I think the jury's out on that. To what extent the capacity is there to do really what are public health interventions. And there's a lot of discussion, and California's got a big effort underway called Whole Person Care, which is really trying to bring together the community-based organizations, the public health organizations, and the medical and behavioral health organizations to deal with these challenges together with the community. And so we'll see, but I think the jury's out on that.
Well, and of course, the new jargon is accountable health communities, new initiative, which, in some ways ACOs are old hat, new jargon, but to describe what I think that you've already talked about today, which is linking with healthcare and social services more formally. So we've run out of time. I think I'm going to leave it there. Thank you for some fantastic questions, and thank you both for some very useful and thoughtful answers. I hope you've got a lot out of it. Thanks again for the questions, and see you again.